Welcome to Passionate World Talk Radio. Educate, enlighten, entertain.
Hello and welcome to another segment of Whine and Cheese. Before I introduce my guest today, I would like to thank Lillian Caldwell, CEO of Passionate World Talk Radio, and Jeannie White, Station Manager of Passionate World Talk Radio. My name is Sheila Wilson, and I am a nurse. I'm president to Stop Healthcare Violence, and I'm also a host on Passionate World Talk Radio. I will be talking today to a psychiatrist that I've had several conversations with before. Let me introduce Dr. Donald. Welcome and to the Whine and Cheese.
Thank you for inviting me.
Oh, you're quite welcome. Let me just give a quick rundown. Dr. Donald is a psychiatrist working in an inpatient psychiatry in an acute psychiatric hospital in Boston. He's also a psychoanalyst in private practice trained by the San Francisco Psychoanalytic and the Boston Psychoanalytic Institutes. He also says he is a cultural anthropologist, Ph.D. trained at U.S. San Diego. Well, that's a mouthful, Dr. Donald. Being a psychiatrist alone is tough, but the rest is just as bad. So, hello and welcome.
Hello. Thank you very much for having me on your program.
Tell me about yourself. Psychiatry is something I haven't worked with, but I've had lots of invitations to go into the psychiatric units for visiting people, and it's a little bit different than I'm used to as a nurse of 45 years. So is it a nice place? Is it safe?
So psychiatry, inpatient psychiatry, is always a little bit of a mystery to people, I think, and as is psychiatry in general. So I'm not surprised you haven't a sense of what it's like. Generally, inpatient psychiatry units, as most people know, these days are locked. It didn't used to be the case 30 years ago, but secondary to all kinds of issues on justifying level of care, which came out of the managed care changes to healthcare, all psych units have become locked because they are justifying level of care. So they are very unusual places, particularly in advanced democracies, actually. But people have to remember, I suppose, that psychiatry is the one branch of medicine where people are treated against their will. And so part of that lock is around the issues of safety, both to the person themselves and to other people. And again, as I say, we are also justifying the patient being held in a hospital, often against their will, around issues of payment and managed care and justifying that level of care. We often do have to help patients adjust to the idea that they're behind a locked door, because that is so unusual, particularly for Americans to experience. And we try to help people understand that the doors are locked not for imprisonment reasons, but for safety reasons, both to self and other people outside the hospital at times. But they're very unusual spaces. And they're very unusual not only for all those sorts of cultural and sort of popular ethical ideas. There's a history of anti-psychiatry which says that psychiatric illnesses are not real, and that also makes it difficult to think of locked units inside the medical system. And finally, I think it's difficult just the idea of the claustrophobic feeling of being locked for people coming into our unit. The other thing I'd say is you have to remember that the staff is also locked in that unit. Of course, we do have keys, which makes a big difference, but that the space of an inpatient psychiatric unit is a very peculiar place and very different to being on a medical unit or a surgical unit, obviously.
Well, it certainly sounds it. Now, this is when somebody comes in. Now, I worked many years in an emergency room, so I know a little bit about the psychiatry part of it because we had a great BEST team in Boston. I don't know if you've ever worked with them. And
no, but I get many of their patients.
oh, lucky. And so they were absolutely, most of them were fabulous, and they really treated the patient great. And it was like a 72-hour hold. Now, I don't know if after 72 hours, you as a psychiatrist would allow them to be discharged and to be able to go home. Now, is that still in existence?
So if you imagine what these legal holds are like, they're part of mental health law. Mm-hmm. And again, we're putting American citizens behind a locked door, which is not a jail. But if we don't have legal paperwork, we're essentially kidnapping people. So all patients that are put in a locked psychiatric unit must have a legal paper trail to justify that action. The first step that happens in an emergency room is usually what's called a 72-hour hold, where the emergency room doctors, there are other people who can sign these, such as police officers, nursing staff can sign, nurse practitioners, for example, can sign 72-hour holds, and they are requests that the patient not be discharged from the emergency room, but go to a psychiatric setting for a 72-hour period of evaluation. At the end of that 72 hours, if the patient does not choose to sign into the hospital, the psychiatric team must make an evaluation as to whether the patient should be discharged or held longer against their will. And they need to meet certain criteria for that, either imminent danger to self, imminent danger to others, or so ill by virtue of a psychiatric illness that they could not care for themselves at all and might, inadvertently die. If the psychiatrist thinks that they meet those criteria, then the psychiatrist must file for a court hearing, and a court hearing will be put into place by the local court, where a judge will hear the case, so that there is, in fact, due process per the Constitution of the United States of America, and the Constitution is recognized and obeyed. At that court hearing, the hospital presents their case for the patient being held against their will and even treated with medicine against their will. And the patient is given a lawyer by the state if they don't have their own, and that lawyer produces the opposite case. And the judge, in some Solomonic way, decides the issue. It can be very dramatic. It is certainly not easy. It can get quite difficult in court with arguments between the lawyers, although it's quite interesting to hear how they think. And at the end of that, the patient either leaves, sometimes to the distress of the family, and sometimes the patient is held and can be held up to 6 months in a psychiatric setting, although usually that is not the case, and the team just simply continues to proceed to treat the patient in the hope that they can be brought back to health sufficient to discharge them as soon as possible.
Well, you mentioned something about the medicine, and they're given medicine even against their will. That's correct, right?
Yes. If the hospital wins that hearing, yes, they can be given medicine against their will. With the beneficent idea, the ethics behind that is beneficence, that this treatment, although difficult, will serve the greater good of the patient in the longer term.
Right.
Right.
I had an instance with this. I spoke to this nurse that was she was working in psychiatry, and she ended up calling me because her patient that just got out of, he was on isolation, not for any reason except that he couldn't be with the population. So he finally got out, and he came into, and she had to give him his medicine, which was an IM shot. And so he was all ready. She explained everything. Now, this is what I'm being told. and she was all set, and so she finally got the injection into his buttocks. He pulled the needle out and jabbed her twice, and this is about violence. And another instance I just want to bring out that you had mentioned. You know, I'm in the emergency room, and I'm working with the other nurses, and there was a patient there we knew that she was violent. But she wasn't tied down, she wasn't medicated, and the nurse comes in, and she asks her, you know, you doing okay? And she said, yes, but for some odd reason, this woman jumped off her stretcher and jumped on the back of this nurse, and it took 7 people to get her off. But this woman, we didn't know too much about her, but we needed to do something for her. And so as I'm telling the story, she ends up being discharged to a psychiatric hospital or a holding unit, that she was brought to court because this nurse filed charges, and she couldn't even hold her head up. She was so what we call snowed. It ended up, to make this long story short, is that we worked with psychiatry. Hand in hand, we worked with them and ended up getting a Rogers. So this would go under this part of being given medicine without their, we didn't need their permission. Is that correct?
So a Rogers order is an order which requires the patient to have a guardian appointed, and the guardian is then appointed by a judge. It usually isn't done inpatient. It really is an outpatient guardian. And it doesn't have a lot of teeth, really. The guardian does not have the right to admit the patient to a hospital or to release the patient from a hospital. But the guardian, in some way, is the monitor of a set of medications which that judge orders as the patient's medicine. Now, if the patient stops taking them outside the hospital, nobody can do anything about that, except encouragement, of course. The Rogers order is useful in the following way. If the patient does get admitted to a locked psychiatric unit, and if the patient needs those medicines in the opinion of the psychiatrist on the inpatient unit, and the psychiatrist has contacted the guardian and has a copy of a current Rogers guardian, the psychiatrist doesn't need to go to court for the judge to order those medicines, because they've already been ordered by a judge, and it speeds up the process of treating the patient inpatient because we can already immediately start those medications that have already been ordered on the Rogers order immediately. So again, it's the principle of having medicines that the patient may not wish to take available a little bit more quickly if you do have a Rogers guardian in place. Inpatient units do a commitment hearing, which is the hearing that comes when the patient wishes to leave and not seek treatment, and the inpatient psychiatrist thinks that it is necessary by reason of those 3 prongs, danger to self, danger to other, or grave disability, and then goes to court for a commitment hearing, which would last up to 6 months. That's not a Rogers order. The Rogers order applies already, sort of carried around by the guardian outside the hospital. But one of the things that you're really bringing up, I think, in terms of your organization's interest is the issue of violence. And, of course, it is an extremely difficult issue, how to treat violence in an emergency room or inside a hospital, or really anywhere, really, isn't it? It is. And also, particularly with patients, how to think about how to hold people with mental illnesses responsible for their violent actions is extremely difficult to think through, but important to try, because the amount of violence that psychiatric nursing staff experiences is extreme. It's extreme. And I don't believe the general public understands what psychiatric nurses have to bear in order to be psychiatric nurses. And they do it out of the goodness of their heart. They do it because they're special kind of people who want to deal with people who are in great trouble. But they really do get assaulted tremendously. And we do know that psychiatric nurses essentially get assaulted more than police officers, although perhaps not as severely. But it's a job which involves a tremendous amount of violence being directed at them. And I think that is better talked about than brushed under a carpet. And, of course, you are dealing with nurses in other branches of medicine who also get assaulted, particularly ER nurses, but also in other ways in the hospital. And it is a problem in terms of the demoralization of clinical staff and losing clinical staff. We are losing a lot of very talented psychiatric nurses who are hard to find in the first place, by the way, because
they certainly
of the violence. Yeah, and so, there's how to manage that and to think about it at a more a theoretical level and at an ethical level, I think is very important for American society, which is not exactly an unviolent society itself. So to think that all through shouldn't be brushed under the carpet, because it is, I think it does make people anxious to think that clinical staff is being beaten up, but clinical staff is being beaten up. And I think it needs to be openly discussed publicly how to manage that in some way.
Now, with saying that,
Yeah.
Dr. Donald, how much security do you have?
How much what?
Security. Do you have security to help with all this violence?
No, but we do have, we don't have security guards, and most ERs do have security guards, as people know. Often inpatient psychiatric units do not have security guards, especially if they're in freestanding psychiatric hospitals. There are a number of reasons for that. But we do obviously have mental health workers who, like nursing staff, are the, they're the real working structure of these units, and they assist the nurses in maintaining the inpatient unit in a stable way. And so if we do have an out-of-control patient, there will be a call, and different hospitals have different ways of doing it, but usually pretty much everybody that's available will turn up on the unit where there's an out-of-control or violent situation happening. They'll also turn up on a unit if there's an acute medical issue too, but since we're talking about violence, all of the psychiatric hospitals have some methodology by which other people will turn up. The problem is that given how difficult it is to be a psychiatric nurse, given that there are not very many of them and we're always losing them because of the difficult job that it is, we often don't have enough staff, and in particularly we don't have enough men. So often dealing with a very violent patient who may be a very large man has to be done by a bunch of rather slender females and female MHAs, and that's not a good situation, because sometimes if you have guys, you have a lot of sort of bulk and you have a holding environment around a violent patient, and all of that leads to more violence on the collective body of the nursing staff. And obviously the nursing profession is female for the most part, and so it really is a lot of women that get beaten up, and it's very, very difficult to to do that job. Inpatient psychiatric units have methods, and if I did have a psychiatric nurse here, she would be able to talk about that much better than I, on how to manage situations. There are, we have strategies for who takes control of the situation, who tells somebody else to do X, Y, and Z. it's obviously a very tense situation, or if you've got a large person throwing chairs and throwing punchers and punching holes in walls and things like that. But usually the nursing staff is extremely adept at managing that situation, but it's an extreme situation, and there's a lot of anxiety. Usually you need an experienced nurse who's been through the ropes like you yourself have to sort of keep an eye on how things are going and make sure that, everything is done as well as possible. The nurses, if they are restraining a patient, want to do it safely. They don't want to harm the patient. And usually, somebody's monitoring vital signs and the well-being of the patient's neck and all that kind of thing through a restraint. But it is an extreme situation which nursing staff has to deal with. And again, it is very difficult. And, if anything goes wrong or the patient does get injured, which does happen, usually it's then very tense because there's a lot of criticism that comes out of a sort of bureaucratic system about why it didn't go well. But, for the most part, these restraints do go okay. But when they don't, I think that there's a lot of blame that goes around, which is also very difficult for people to manage ethically.
Right. Now, when I worked in the emergency room, we had several security guards throughout the hospital, but then we fought to get in a security guard right there in the ER 24/7, and that eventually worked. However, now I'm hearing that all our security guards are hands-off, and I'm not sure.
You're not sure why.
Right. I'm not. The only thing I could think of is the hospital got too many lawsuits. But before I go into that, as a physician, as a psychiatrist, have you ever been assaulted?
Yeah, I've been assaulted multiple times, and so have my colleagues. Inpatient psychiatrists, apart from all doctors, are the ones that get assaulted quite a lot. We don't get assaulted as much as the psychiatric nurses because they're usually helping to protect us. Thank you very much. But we do get assaulted. We see people. The people that are going to be placed in a psychiatric unit, there's a certain subset of them that are going to be very difficult to manage. They're either very psychotic, or they're very angry, or they're very confused. And so, the chance of the quotient of potential violence is above most other medical settings. So it's just, that is sort of what you have to know if you're going into inpatient psychiatry. But again, I think that the issues here, they're complicated issues. Like, for example, how many nurses should you have per patient? Do you take into account can you put a number on how acute a unit is? And in that case, do you need more nurses and more mental health assistants to maintain the stability and sanity and serenity of that unit? All kinds of things like that, I think, need to be discussed more openly. I mean, the Department of Mental Health has certain standards for how many nurses per patient. But, nurses are expensive, and there's always sort of this contentious balance between cost versus safety, which is difficult to negotiate sometimes, In terms of security guards can be very useful, and if they're well trained, they are able to be quite safe in dealing with a violent patient, and sometimes very, very helpful. But again, we are dealing with perceptions of law and order and the patient as a concept. And so there's discomfort, considerable anxiety and discomfort thinking through the necessity to contain a patient. The whole notion that a patient should be contained and injected against their will makes people very anxious, not only psychologically anxious, but I think ethically anxious. And so there's a considerable amount of avoidance by, the public, by hospitals, by administrations in thinking that through. And lawsuits are part of it. I mean, it's a very litigious society. And you're often in double binds around this issue. Patient acting out can damage themselves terribly. But if you constrain them or restrain them in the hope that this is going to contain the situation and there is an adverse event, then yes, you're open for a lawsuit. If it's a security guard doing it, if they're not medical, perhaps administration see that bigger medical legal risk. But the underlying issue here is, how do we ethically hold patients responsible for their actions? And that is very, very ethically uncomfortable for people to think through, particularly in America for some reason. I guess you can hear from my accent that I'm not originally an American. I am now. But
no, you didn't come from South Boston. That's for sure.
No. So, when I went through medical school and we were taught ethics, obviously we were taught the ethics of our responsibility as clinicians, but we were also taught about the ethical responsibility of the patient role, and that the patient has ethical responsibilities to inhabit the role of the patient. And I'm not sure where the latter piece of that ethical dualism has gone in America. And so I think it's then very difficult to talk about this without a lot of anxiety and a lot of pointing of fingers and a lot of angry argument. And it makes it very difficult then to think through the problem of violence by patients towards healthcare staff. But it has to be.
Nobody seems to want to do anything against the psychiatric patient. If you say, I'd like to bring it to court, no way.
Yes. It's very, very
I don't know why. Because I feel that the patient needs to be held responsible, of course, unless he's really psychotic. But there has to be something somewhere on an even keel that when a psychiatric patient assaults you and now you're out on disability, so forth and so on, they need to be held responsible. It's not, we make up excuses for these folks, and not just those folks, but a lot of other folks too, and that's why we're not getting anywhere in healthcare violence. But people are afraid. They don't know enough about psychiatry.
No,
maybe because we haven't, we haven't taught ourselves. And we say, oh, he's a psych patient. Okay, let's let the best team take care of it, and then it goes on and on and on. Oh, he's going upstairs. Oh, he's going to have a sitter. And that's the end of that. Yeah. But the DSM book, how many diagnoses did it have 40 years ago when I first started nursing compared to today?
Yes, well, they change based on culture and politics, DSM's an interesting document.
Well, you're right. But I think
what you're saying is it's very, very, it is very complicated to think it through, because psychiatrists do have different diagnoses, and we are forgiving of being assaulted by somebody who is in the throes of a delirium where they don't know what they're doing at all, or a psychosis where their ability to test reality is so distorted by delusional or perceptual problems that they really also cannot be seen to be capable of making a rational judgment. But there are registers of rationality here. And so the idea that every psych patient should be released from ethical responsibility for their actions, I think, is a mistake. It can be thought through, and yes, it is very complicated, but I think most psychiatric staff eventually, if they get to know a person well enough, can judge how much that person has the capacity or the capability to actually be responsible for their actions. The other part of this is it's about a holding environment around the patient. If people are acting out, I mean, they're violent or they're impulsive, there is really very little way of having a conversation. And it is only with language that we can learn about ourselves and understand ourselves. So there has to be an ethical boundary around behavior, because if it is simply allowed to happen, there is no possibility of understanding anything, either by the patient, most importantly, about themselves, or really amongst the staff who would not be able to really have a conversation with a patient who's about to punch them. So a holding environment which actually places the safety of the staff as an equally important component to the safety of the patient is, I think, a necessary conception around a safe holding environment in healthcare. And I do think that there has been a forgetting of how much violence nursing staff actually puts up with, and that is not healthy. It's not healthy for having a functioning healthcare system. Right.
No, I'd like to ask.
Britain is complaining about this too. Nursing staff in the NHS is complaining that violence levels are going up, and of course it's very interesting to wonder why they're going up. Right? What is the deep cultural and social reason for increasing levels of violence against healthcare workers? And there wouldn't probably be one theory about that, but that is worth thinking about.
Well, I think
if you just have
part of
the patient. Go ahead.
My cohorts would say the violence is going up because they can. There's nothing that's being done about it, and they're so sick and tired of being punched and kicked around and thrown to the floor, kicked in the face. And just one question before I need to let you go here. Our time is almost up. Did the facility help you at all when you got assaulted, or when you get assaulted? Do you write out incident reports and go through risk management and anything done? You take time off, or?
No, I didn't. No, the nursing staff had to write things up, because the nurses always have to write everything up. As nurses know, you're overwhelmed by bureaucratic forms, right? The doctor doesn't have to do that, and I'm very glad not to do it. I had to go back to work the next day because I had to take a patient to court, and there was nobody to replace me, and I was stabbed in the face, actually. So I had, bloody bandages and everything, and the person that actually had stabbed me was in the next court. So it was rather dramatic, actually, because the judge apologized to me that it had happened to me, and was also the judge on the other case. But there's not a lot of processing that goes on formally or structurally in the hospital. And to tell you the truth, I'm not sure that the psychiatrists really would want that. I mean, we are trained to think about ourselves, and, we try to work it through. And, I talked it through with my nursing colleagues, who are extremely helpful, of course. And, but not a lot, no. My colleague who had her arm broken by a patient slamming the door on it several times did take a few days off because she had a cast, but then, she did come back to work. So there's a sort of, I've heard you say this, or I've read something that you've written, that the notion that you just have to put up with it because it's part of your job is not an appropriate response to the violence that nurses put up with. It's just not.
No, and it's not even in our job description. But before I go, before we need to stop this, I had the opportunity of having to visit a relative in a psychiatric hospital. And actually, I had to go several times. I didn't have to go. I wanted to go. And I ended up meeting most of the nursing staff because this person was just just a person that was having some trouble, stopped the medication that he was on, and he just ran into a lot of trouble. And I have so much respect for psychiatry and the psychiatric nurses, because each and every one of them, even though they all knew who I was visiting, they all seemed to know who's who in that unit that was visiting the client. They were so helpful, and they would come and sit and they'd ask, is there anything that we can discuss? Is there anything that you want to know? And, of course, the person had to say yes or no, but they were there. And there was only one psychiatric hospital that I had to visit that I felt unsafe. Mm-hmm. But I got to hand it to you guys. This is, and as I said before, I was in nursing for probably 45 years now, and I wasn't safe in the ER, but in the psychiatric arenas that I went to, I was very safe in. And I understand that you get assaulted and all sorts of all that, but maybe I just have a lot of respect for you. So I just want to say that before we end.
Thank you. I have a lot of respect for the psych nurses too.
That's Dr. Donald, would you ever want to come back on so we can talk more about psychiatry?
Sure, absolutely.
All right, and maybe you could get another nurse. Maybe you could get a nurse to come on and talk about maybe how does she know when somebody is going to lose it? How does she know how to get them back on track?
Yes.
That would be
that would be very interesting.
That would be, and no, everything is fine. And I thoroughly enjoyed your conversation. And so why don't we plan on maybe in a month? Maybe you could do it monthly and teach us about psychiatry.
Okay, that would be fine. Thank you very much for having me on your program. I do appreciate it very much.
Oh, I think this is wonderful. Thank you for being on. This is Sheila Wilson signing off from Passionate World Talk Radio, Whine and Cheese with Dr. Donald. Thank you very much.
Thank you for listening to Passionate World Talk Radio. You can listen to this program all over again by going over to https://passionateworldtalkradio.com. You can also hear it on Spotify, Spreaker, Amazon Alexa, AMFM247.com every Tuesday evening between 8 and 9 p.m. YouTube, Facebook Live, LinkedIn, and all the other podcast directories one can find on the Internet.